I'm glad Dr. Kais took us a little bit into data. And now our next presenter is Dr. Patrick Marius Koga, Associate Professor and Director of the Ulysses Refugee Health Research Program in the Department of Public Health Sciences at the UC Davis School of Medicine. Dr. Koga research ranges from trauma resilience in refugees, selfhood and idiom of distress along the acculturation continuum, over medicalization of refugee suffering, violence against women, M-Health, and Ulysses syndrome. Also, I'm a physician and an Afghan. I have learned a lot about Afghans from Dr. Koga. I have the honor of being Dr. Koga mentee during my work with UC Davis. And Dr. Koga, it's so honored to have you today, please.
Thank you all. I want to bring a different layer of complexity to the issue at hand, which is idioms of distress and explanatory models and how that relate to instruments and how do we know that what we think we know is truly the diagnosis that we formulated. As pointed out by Dr. Sadiq before, and then Dr. Alemi afterwards, there are 9 impacted counties here in California, and we have the largest number probably now here in Sacramento. People bring, as mentioned before, pre-migration, during migration, and post-migration and post-resettlement traumas, but for children, these adverse childhood events are extremely harmful, and we want to go through trying to understand how Afghans make sense of their distress, how do they express it, and how do we actually recognize that. You heard the word PTSD, post-traumatic stress disorder. So when something horrible happened, such as the fall of Kabul and trying to escape from the country, to seek refuge, you try to make sense of what is happening. It's very important with any physical or mental illness in order to reclaim control is to make sense. How do we explain that? What's the explanatory model for this? And then how do we communicate what is happening to us? How do we cry? How do we seek help? These 3 steps are sequential and extremely important. So now, meaning is very different from one group to another group. I remember some of my years in South Africa, working with the University of Cape Town, seeing schizophrenia, which is called Amapofayana, and in the Koga people, demonic possession, exhibiting psychotic behavior, and all that with requiring a Sangoma intervention. I would call it schizophrenia, but they were 2 different things. There's no equivalence, as a lot of transcultural psychiatrists or psychologists would think that this means that mal de ojo means this, and ama perdida or jigare kun means this. It does not mean clustering is very different. So, how do Afghans conceptualize? How do they understand mental distress? Afghans, just like Uzbeks and Kyrgyz, have 3 categories of mental distress, three roots. One is caused by the biology, like schizophrenia. Another one caused by jinns, by spirits, that can take over a person's mind. That's why you have in Arabic, you have majnoon, a person who is possessed by jinns, right? So it's a spiritual realm, is a biological realm, then is a life realm. In most cases, Afghans think that the cause of suffering is bad life, horrible events, not mental disorder, not biological, right? And we try to sometimes to over-medicalize that and to overlook what they actually think is happening to them. And how do they express this? The expression of suffering, whether is, as they call it in Naharat, asabi, or fishare bala, fishare payin, as they name them, these are culturally programmed, so to speak. They are uploaded in kids through upbringing, and there are like validated and normal ways of expressing suffering. And that's different from culture to culture. That is extremely important. And people bring with them not only their physical body, but also their cultural value orientation and their idioms of distress, which are to be recognized by practitioners. So let's go through a few idioms here and a cultural bound syndrome. Asabi. Asabi in Arabic means nerve, right? So nervous. So same in the Afghan. Asabi means highly stressed. And this condition may progress into naharat, which is severe discomfort with anxiety or depression. So it's moving along the spectrum. The person may describe also that they have fishare bala or fishare pain. These may be translated poorly as high blood pressure, low blood pressure, when they actually mean high emotional pressure, low emotional pressure, right? Some would misread into fishare bala, maybe a hypomanic episode. It is not. It is something else. It's just fishare bala. What is jigar kun? My liver is bleeding. Unlike the Arabs, they would say my heart is broken. The Syrians, right? The Afghans, the seat of the soul, they would say my liver is bleeding. Yeah, jigar kun. Our colleague Ken Miller, that worked with Kai Salemi in the past, and we were in the same Afghan research team group, did an amazing study in Afghanistan and developed this Afghan symptom checklist. And he introduces these terms, fishare bala, fishare pain, jigar, and also thinking too much. Thinking too much is part of many cultures. It's an idiom of distress that brings additional things such as functional impairment and cognitive somatic symptoms, but also, more importantly, shows progression to psychosis. The fear, the cultural fear, is that thinking too much will lead to craziness. Now, are these carved in stones, these ways of communicating? We think not. So in a study that I conducted at Sacramento County Refugee Health Clinic years back on a pretty large sample, 1,600 patients, and subsequent study, I looked at how the expression and the attribution of cause to depression changes in acculturated Afghan women. So, for example, if you look at the Afghan female patients, the first generation, there's the mother. How do they express? What's the idioms of stress? Well, they had affective symptoms such as sad and angry, feeling lonely, isolated, having migraines, the somatic veins pulling neck and burn. They also say that they have fishare bala, or they have fishare pain afterwards, deep, and naharat. So they use those terms as well. And what I was surprised to find out that many complain of forgetfulness. And I've seen women in 40, and I tended to do a lot of mini mental status exam, like to see they're going downhill. And I was fooled by that because I didn't see cognitive losses, but they are culturally programmed to say they have memory problems. Well, that changes in their daughters. So when we look at the sample of younger generation, there's no more, veins behind neck, pull and burn, less fishar bala, less jigar khun, and more affective symptoms such as low self-esteem. The Afghan mother, never heard of low self-esteem in Kandahar. There's no such thing. And hopelessness. That's not all right for a Muslim when they believe in Allah, right? There's no hopelessness. That's haram. And then worthlessness. Afghans don't think they're worthless. These are borrowed, acculturated Western concepts and Western metrics that have already changed in the data. So when we think Afghans, as Dr. Alimi said, which Afghans? Are they Hazara? Are they Tajiks? Are they Pashto? Are they Wardak? Are they first generation, 1.5 generation, second generation? All depends, right? So, when we look at the causes that they attributed to repression, the first generation said, yeah, I left my old mother, ill mother behind in Kabul. I feel so guilty. I need to do something, and I have no money to help. I fear for my kids. They're going to lose their roots. I am ashamed because of poverty. I can't speak English. There's intergenerational power change, reversal. My kids are taking me to medical appointments. I feel I have no power, no authority. Second generation, Afghan kids, especially girls, find trapped themselves between two cultures, almost belonging to none. So different expectations of norms at home, different outside, different judgment, how to behave. That is a problem. So now they would attribute their cause of depression to this dilemma. Now we talk about what is Afghan selfhood, how it is conceptualized. Is it collective? We use a lot to throw around the word collective without understanding all the details and nuances of that. Is it embedded? Is it relational self, like the Lebanese or the Syrian? Is it exactly, how does it work? So how it is expressed, how it is lived, how does it change post-resettlement or does not change? 60 years ago, Barry brought this model of acculturation, and it have gone through many, interpretation and rehauls, and it's not good enough yet, but it's a work in progress. So Barry says you come to this country as Afghan, and you either become bicultural if you're young enough, like 1.5, and you manage both cultures, you're swimming in both, seas, and you function very well, and you move upward. Or you are too old and you do not integrate, you separate, you speak only, you live in little Kabul, in Fremont, and talk about the past and about the Soviets, right? With only your people. Or you assimilate and dissolve in the American Sea, and you lose everything Pashto in you. That's not possible, but sometimes it does happen, and studies show that leads to poor health. Even worse, in some people, they lose their Afghanness and they gain nothing from the American identity. That is the worst possible outcome. But Barry, creating this matrix, has neglected that this is bidirectional, not only one way from the Afghanhood to Americanhood, but it can go backwards. And it does actually, by cultural people return. Sometimes they start rejecting things. So there is also inculturation, not acculturation, where the things are more nuanced, where people can choose what to keep, what to adopt, what to reject, and what to blend. And you see that a lot in the younger generation. So a new Afghan selfhood is emerging. How do you capture that? How is that captured in instruments, assessment instruments? How is that taught and disseminated in terms of policy and best practices and in translational research? So we also know that it's not always very good to change. And we see from our colleagues from UC Davis, from Dr. Sergio Gaxiola, and from colleagues from UCLA, Vega and others, they say la cultura cura, which means the culture cures in Spanish, that staying within our culture, you're more mentally healthy than to change your culture because it takes so much stress to adjust. And it's not easy to happen. To make an evolutionary change in a lifetime, what has taken like centuries for the Pashto identity to be distilled in a natural landscape. So the immigrant paradox is to be kept in mind. Now, what do you do with the young Afghan, with your daughter marrying a Russian here in Sacramento? Right? Because the father lived in Russia, some years back, right? So what do you do with mixed marriages? How much Afghanhood is in that? We see the American process of nation making that this does happen. If it did not happen yet, it will happen in the future. So we don't have models for that, lessons for that. So when we talk about, and we'll hear from our colleagues, validating instruments, how do we validate instruments? For which Afghans exactly? There's no generic Afghan. Look at this. PTSD is disease, right? It's in the book. Any psychologist, psychiatrist is going to tell you what is it exactly. But for Afghan, maybe this makes no sense because their meaning-making or explanatory model says this is jigar-e-kun. This is not what's PTSD. Then the same people with PTSD, 10 people, or all of us that have PTSD, say here, will have different ways of expressing this and living our suffering individually, subjectively. So the subjective experience of a disease is called illness, which is very different. The doctors are treating ill people, not books, not, bookish constructs like PTSD, which is a disease found in the books. And then you have the sickness. What is Medicare saying about this? What are the best practice policies and insurance codes saying about this? Yeah. So you have now three conflicting aspects of this triangle. One is the explanatory model, the way diagnosis is constructed. Second, illness, the way suffering is expressed and understood. And then what do you do about that? How the professional guild work with that? Imagine the permutations and the arrangements, the combinations are almost infinite. You're going to create a major confusion for providers and patients alike. And good luck to figure out a good system that's working. And we have to work because it's a multicultural state. We are in California, right? We're leading the nation into that. So we move from cultural blindness, we're all the same. We're not the same, we're different, and we take pride in that. We're not only culturally sensitive, we're competent. But what is competence? Competence takes me about 100 years to arrive to that competence, given the complexity and the fluid nature of selfhood change. So when we create new instruments, let me validate this tool for Afghans, like, Back's anxiety inventory, Back's depression inventory, or PCLC. I try to do that. I may be creating a new artifact to replace the old artifact, the American artifact, unless I understand that this is going to work only for a certain group of people, a certain subgroup of Afghans. So how do we do that? And lastly, when we talk about kids, how is jigar-e-kun or fishare-bala or fishare-payin or nahara expressed in Afghan kids? We don't have enough studies looking into that. We look at the adults because we think, knowing about the Afghan family, we have to support parents first. We didn't look much into kids. We didn't look into elderly. And Afghan also got old, and we need to have more data and more knowledge about the two extremes. So regarding kids, we don't know to what extent the Afghan kids are having introjected, uploaded, so to speak, the idioms of distress from the families and culture. They express it like the adults in a milder version, aside from acting out another thing. What are the studies? We need to do that. Secondly, we talk about ACEs, scale, we talk about PERS, that is introduced at the Sacramento County, Refugee Health Clinic. Colleagues from the pediatrics department are working now under Dr. Young, Professor Young, to retool that instrument. So we need to have the tools, the assessment tools retooled based on focus groups, based on what the Afghans are telling us, and then validate that. And we need to have a wide variety of subgroups. We need to have different ages. We have to have Tajik and Hazara and all the groups, Pashtun groups and so forth. And what do you do with also 1.5 generation or bicultural or groups that are changing? And to what extent that's going to be good if the arrival stops and the population moves along the acculturation continuum. These are important things. That's why we all are trying to come together, researchers, and put together and create a larger body of knowledge so we can inform policy changes. And thank you. I will take questions.
My name is Hadi. I'm health case worker for International Rescue Committee, Sacramento office. I belong to Afghan community, and I've been living here for 2.5 years now. Kind of new.
Okay.
I was impressed really by the profound definition of terminology and different terms that you have used, like jigar khun, fashar bala, and fashar pain. I've noticed them, but I haven't gone that much deep into that really using different terminology conveys different meanings in terms of having mental health conditions. But specifically, my question was that you emphasize that when you interact with the clients or with the patients, you have to acknowledge their ethnicities. Like you mentioned that there are people, their ethnicities are Pashtuns, Hazaras, Tajiks, and so forth. What are your findings, and what are the differences between those ethnical groups, and how do we find the differences, and what specifically you mean that we have to interact differently?
There are Afghans, so there is an Afghan context and an overarching Afghanism. But, for example, when you have this more proximity in terms of idioms of distress, Jigarikun, Sharabalaf, Sharapayin, Narat, Asabi, in between Pashto and Tajik, because it's basically Persian influence that came from time, but it's less so in Hazaras, right? In Hazara, things are, a little bit more different. So the expression of idiom of distress is different. And it would be interesting, we don't have a large number of Hazaras, we still get some Hazaras to do like a Hazara study, a comparative study with Pashtuns versus Pashtuns and Tajiks. Yeah. Let me give an example of clinical difficulty. Okay, so this is Maknoor, a Pashto refugee woman with Jigare Khun case. She's not using services. 36-year-old woman saw the killing of the eldest son the year before, and she said, Jigaram Khun hast. My liver is bleeding, and her fishar was high, fisharan balahat. Maknoor is grief-stricken, anxious, as seen in her naharat. She has found herself thinking too much about the images of her son's body. So now, of course, Maknoor knows that liver is not bleeding, it's only metaphorically bleeding, but it points out her grief that is so physically manifest. And she displays aggression, is beating her kids, anger with her disabled husband. She's definitely aware that she's not functioning well. She is definitely literate. But her health literacy is not American health literacy, it's Afghan, it's Pashto health literacy. If she's illiterate, then perhaps the provider is also illiterate. So how do we deal with that? So as providers, make sure before you jump into health literacy campaigns that you work together. That is not only your health literacy, but their health literacy, and they work together to create a better lexicon. That's important, because if that is not there, people feel disempowered and dismissed. And that's why she did not want to go to services. Aside from that, it will go against her cultural norms because she has to see so many men. And that is a perennial problem. Yeah. So these are important practical things where you have behaviors, culture, and idioms of distress, and cultural rules about help-seeking behavior. Thank you.